Just 1 second, doctor. It's asking me for permission.
Yes, yes, in your slide.
You can see it?
Yes.
Yes. All right, thank you. All right, assalamu alaikum everyone. Good afternoon, good morning, and today we'll be talking about whooping cough in children. My name is Yazan Al-Khatib. All right, so our objectives is the epidemiology, etiology, presentation, diagnosis, treatment, and the complications of whooping cough. All right, for introduction, first we need to know that pertussis or whooping cough is a highly infectious disease of the respiratory tract caused by a gram-negative bacteria called Bordetella pertussis. It is mainly transmitted airborne, and it more commonly presents in children. Airborne means it can either be transferred from person to person directly, or it can land on a surface, and a person can pick it up off a surface. It's characterized by intense paroxysmal coughing that is followed by a distinctive whooping sound on inhalation, and in some cases, vomiting. Epidemiology: highest incidence of morbidity and mortality consistently in infants less than 6 months of age who are too young to have completed their primary immunization series. Vaccination has reduced the global burden of pertussis by over 90% compared to the pre-vaccine era. Pertussis is more commonly found, or it's like more present in countries such as US, Europe, Japan, North and South America, Australia, and New Zealand. Now, what is the cause of increased incidence? Now, just a heads up about Bordetella. You should know that Bordetella pertussis, a way to get rid of it is through vaccination, and so an increase in incidence would due to under-immunization, vaccine failure, insufficient vaccine coverage, changes in vaccination calendar, more effective diagnostics, increased public health reporting, and waning vaccine-induced immunity in adolescent populations. Now, a thing about Bordetella is that recently, with all the vaccines, it has found a way to escape the vaccination. So as he mentioned, increase in the number of isolates not expressing vaccine antigens in the particular P-tactin, Bordetella pertussis strains show evidence of genetic selection for vaccine escape mutants, and that's what I was mentioning, with changes in vaccine antigen expressing genes, some of which may have increased the virulence of this pathogen. Recent evidence demonstrates that the circulating Bordetella pertussis strains have undergone significant genetic changes compared to the pre-vaccine era strains and a whole vaccine era strain. I think it's pretty self-explanatory, but again, it just mentions that before, when there was no vaccines, there was no such thing where the Bordetella would undergo the vaccine antigen expression changes and represent again with a more severe symptom. Now, the etiology of Bordetella pertussis, you should know it's a gram-negative aerobic Coccobacilli with a fastidious growth requirement. Strictly human pathogen, so it only infects humans. Now, and regarding the virulence factor, I will talk about it later in my next slide. Now, how again we transmit it? It's an aerosolized droplet by coughing or sneezing. Now, the CFU is around 100. Okay, CFU means the colony forming unit, and it is a very low, which is about 100 bacteria. Although it's very low, but it is severely and highly infectious. Older people are usually the source of the infection in children. Incubation period is 7 to 10 days. Most contagious cough is in the first 2 weeks of the cough. Now, incubation period is 7 to 10 days. Why? Because when the bacteria lands into our system, or mainly the trachea, it takes time until it multiplies and starts forming the symptoms. And now we're going to talk about it in details in our next slide. Now, the pathophysiology of this disease, again, we inhale because it's an airdrop transmitted disease, we inhale the bacteria into our trachea. Its virulence factors facilitates its attachment to the cilia or to the epithelium of the trachea. Now, the different virulence factors that help it attach to the cilia, it's the filamentous hemagglutinin, pertactin, and agglutinin. Now, what they do is they help in the destruction and the paralyzing of the cilia. This causes the accumulation of mucus and a decrease of movement out of the trachea. Now, what also happens is that you have the pertussis toxin. It increases the T cell population at the area, which leads to increased permeability near the blood vessels nearby, which will lead to increased edema, which will lead to even furthermore increased secretions and mucus in our trachea. What also it releases something called the adenyl cyclase. It prevents the phagocytosis of the bacteria. In addition, it leads to the destruction of the phagocyte itself. All right, apoptosis of the phagocyte. Now, the way it presents actually at 3 different stages. The 3 different stages are the catarrhal stage, paroxysmal stage, and the convulsant stage. In order, this is how they happen. And the first one takes 1 to 2 weeks, the paroxysmal takes 2 to 6 weeks, and then the convulsant stage can last up to months. Now we're going to talk about each one individually. Now, catarrhal stage is day 1 to day 14. Now, the symptoms are not specific. Again, it's hard to diagnose Bordetella pertussis or whooping cough clinically because it can appear as any other viral infection that we can get. The cough gradually increases with time. You can have conjunctivitis, and it is highly contagious at this month or at this time because the bacteria is reaching its highest level at this stage and at early paroxysmal stage, which is the next stage. So early paroxysmal and the catarrhal stage are the most contagious stages of this disease. You'd have in the paroxysmal stage, which is week 2 to week 6, intense uncontrollable coughing, followed by a deep loud inhalation or high-pitched whooping sound, may be accompanied with shortness of breath, cyanosis, tongue protrusion. Extensive coughing is also followed by vomiting, post-tussive coughing or vomiting. Now, in these 2 links, I put a small video. I want you to see how it appears in children and how it appears in adults. I'm just gonna screen share it with you so you can all see it. Second, I'm just gonna share my screen itself so you can all see it. So this is how it usually appears in children. Can you guys hear it? If you can hear the whooping, which is the inhalation after the cough, if you concentrate. All right, so this is an example of how it appears in children. Now, I found a very nice example, which is how it appears in adults, and I think you should guys all have a look at it, which is this one. This is when it's very severe at an older age. All right, I think this is enough. We can jump back to the. All right, back to the lecture. Now for the convulsant stage, which is more than 6 weeks. Can you guys see my screen?
Yes, sir.
All right. Which usually lasts for more than 6 weeks. During this stage, it's where the symptoms start to decrease or reduce, the whoops slowly start to disappear, and then you would have full resolution in a few months or in a few weeks' time. Now, how do we diagnose patients that come to our clinic with such symptoms? First, we need to take full history. Now, for physical examination, usually patients who have a cough for more than 2 weeks are easier to examine because they tend to present with the whooping. Now, how do we also diagnose? We usually use the nasopharyngeal specimen, aspirate, or just a swab. But our gold standard is we use culture using a special media known as the Regan Low agar within the first 2 weeks. The sensitivity is 20 to 80%, but the culture lacks sensitivity. The PCR to detect pertussis antigens, consider reference laboratory confirmation per nasal swab. Serological tests can be confirmatory in the convalescent phase, and blood work CBC to find the degree of lymphocytosis. What's important about the lymphocytosis, as the lymphocytosis increases, it means the patient is facing a more severe case of whooping cough. Now, for our differentials, again, as I mentioned before, it is hard to differentiate it early on because it can appear like any other flu. But these are specific ones you need to focus on. The Portadella parapertussis or Portadella homsi, which causes a similar but milder illness, and is not prevented by the Portadella pertussis vaccination. It could be Mycoplasma pneumonia, Chlamydia pneumonia, adenovirus, respiratory syncytial virus, or other viruses in general. Now, what is the treatment? Now, you need to focus on the age. In infants, actually, this treatment is usually given in the catarrhal or in the early paroxysmal stage. In infants less than 1 month, we give them azithromycin. But if erythromycins are contraindicated, associated with infantile hypertrophic pyloric stenosis. In children more than 1 month, we can give them any macrolide. If macrolides are not tolerated, we can also use trimethoprim sulfamethoxazole. What are some complications we can see in infants and young children? We can see hypoxia, apnea, pneumonia, seizures and encephalopathy, malnutrition, ALTE, and death. The force of the paroxysm may cause emphysema, epistaxis, subconjunctival hemorrhages, and hernias. The most permanent disability we find in such disease is encephalopathy. Now, how do we prevent it? Again, this is the most important. Prevention is always better than treatment. We usually recommend DTaP, which is recommended at 2, 4, 6, and 15 to 18 months, with a booster at 4 to 6 years, and has an efficacy of about 70 to 90%. A Tdap, which is a single booster dose, and is usually recommended at the age of 11 to 12 years, and a dose for each pregnancy during the 25 to 37 weeks. This is a case study that I had a look at, and I think it would be nice if you guys went through it. Basically talks about the common pathogens in hospitals that have to do with Portadella pertussis causing acute respiratory tract infections. Now, a question for all of you, but I would need a volunteer to read the question, please. Can someone read the question? Yes, go ahead, please.
So a 15-month-old girl is brought to her primary care physician for a follow-up visit to receive her 4th dose of diphtheria tetanus acellular pertussis DTaP vaccine. She is up to date to her vaccinations. 3 months ago, she received her first dose of measles, mumps, rubella, MMR, first dose of varicella, 3rd dose of Haemophilus influenza type B HIP, 4th dose of pneumococcal conjugate, PCV13, and 3rd dose of polio vaccine. 13 days after receiving these vaccinations, the child developed a fever of up to 40.5 degrees Celsius and had 1 generalized seizure that lasted for 2 minutes. She was taken to the emergency department. The girl was sent home after workup for the seizure was unremarkable, and her temperature subsided with acetaminophen therapy. She has not had any other symptoms since then. She has no history of serious illness and takes no medications. Her mother is concerned about receiving further vaccinations because she is afraid of her daughter having more seizures. Vital signs are within normal limits. Examination shows no abnormalities. Which of the following is the most appropriate recommendation at this time? A, refrain from administration of the DTaP vaccine. B, administration of the DTaP vaccine with prophylactic aspirin. C, administration of the DTaP vaccine as scheduled. And D, administration of the DTaP vaccine with valproic acid. I'm going to go with C. You give the DTaP vaccine as scheduled because she didn't have any allergies towards the vaccine. She just had a seizure and it had no other symptoms and it was controlled.
All right, thank you, Rahaf. Now again, the answer is correct, thank you. Now the patient is 15-month-old, so at 15 months she's supposed to be receiving her 4th dose of DTaP. So the only way we would not give someone the vaccination is in 2 cases, either due to a severe allergic reaction to the vaccine and an encephalopathy that is not due to any other cause within 7 days of the prior vaccination. So yes, it is right. We give her a DTaP as follows, her age. And this is an explanation of what I just said, if you guys are interested, read it. These are my references that I used for this presentation. Thank you all, and if you have any questions, please let me know.
Thank you very much. Actually, again, very well prepared and presented. Just before, I am going to ask one question, but in terms of the answer of the question, the answer is right, but the explanation is not accurate. Now, in your case, the fever occurred really quite late. And usually with DTaP, as you know, the most common side effect include, but the fever usually occur within a short time, probably 24 to 48 hours. So the explanation, which has to do with allergy and not, is really not the right explanation. Usually, as you know, there is 2 vaccination, and the pertussis here is the acellular pertussis, which usually has a little bit side effect in terms of fever from the whole cell pertussis, which has been used before. Now, my question for you, how you can prevent the pertussis in a 1-month-old baby or newborn?
Doctor, you said how do we prevent this disease in a 1-month-old?
You were asked this question. You mentioned in your presentation that below 6 months they have more severe disease, and this is really right. So somebody is asking you, how can you prevent pertussis in a 1-month-old or in a 2-weeks-old?
Mainly, we can decrease their exposure to the.
It is in your presentation. It's in your presentation.
Now, doctor, according to my presentation, we prevent it by giving DTaP, but DTaP is given usually at 2 months.
Okay, so how we can prevent it? You are quite, your answer is right. So, the first vaccination to prevent pertussis is usually given at 2 months. So what about before 2 months? Can you prevent pertussis before 2 months?
Not really. I don't think so.
Okay. Doctor, I have a question. Can we give it at birth?
No, definitely you cannot give it. Can you go back to your slide presentation when you, the slide about your vaccination in general to prevent pertussis? Can you back to that slide?
Yes. Just give me a second. Yes, there it is. Can you see it?
Okay. So 1 dose of each pregnancy at 26 to 37 weeks should be able to prevent pertussis during the first 2 months. Usually the antibody will transfer to the baby and will prevent him from having severe disease during the 2 months. And this is the reason Tdap is now recommended, and it's really part of the care provided to pregnant women. So this
Yeah,
is because we cannot give the pertussis vaccine to newborn.
it was actually mentioned in the article I read, and I can't believe I forgot about it. But yes, they mentioned that giving the vaccine at the first trimester can pass through the placenta and give the baby the natural or passive immunity.
And your presentation is good, but and I think really, whenever you prepare, this is for you and other medical students. Whether exam or in life, you know the knowledge, but how to apply it, sometimes there is some difficulty when you ask a scenario or you ask direct question. So any more questions from the group?
No, thank you.
So if not, thank you very much and have a productive and safe week. يعطيكم العافية.
يعطيك العافية دكتور.